Hello, and welcome to the Medicinal Chemistry course presented by Paracetamol Academy. Today, we are going to be discussing antipsychotics, and this presentation was presented and prepared by me, Carl Bushara. The content is as follows, and we're going to get right into it. Antipsychotic drugs are a class of medicines used to treat psychosis and other mental and emotional conditions. They are used to treat a variety of mental diseases, and there are two major classes: the conventional, typical or first-generation antipsychotics, and the newer, atypical, second-generation antipsychotics. Hopefully, by the end of the presentation, you will have a clearer understanding of the difference between these two classes. We are mainly going to be discussing the implications of antipsychotics on schizophrenia, and as such, it's important that we grasp the basic principles of that disease. Schizophrenia is a severe mental health disorder characterized by disturbances in thought processes, perceptions, emotions, and behaviors. It affects the way a person thinks, feels, and acts, and often leads to significant impairments in daily functioning. Individuals with schizophrenia may experience a range of symptoms that can be classified into three main categories: positive, negative, and cognitive symptoms, as seen in the picture below. Genetic factors can increase the likelihood of developing the disease, but there is no single gene that is implicated. Environmental factors are also being investigated, specifically the prenatal and perinatal risk factors for brain damage. The dopamine hypothesis arose from observations after administering the first antipsychotic drugs that affected brain dopamine metabolism. The hypothesis states that the disease comes about because of an increase of dopaminergic neurotransmission, so decreasing that neurotransmission would theoretically alleviate the psychotic symptoms. But it's these effects of the drug that produce the Parkinson-like symptoms, also known as the extrapyramidal side effects. However, there is some evidence that contradicts this statement. Firstly, there are first-generation drugs that are not effective in all patients, and newer antipsychotics are just as potent despite their lower affinity for dopamine receptors. Finally, drugs that block the NMDA produce more schizophrenia than other drugs that promote dopamine. These factors may suggest the involvement of other neurotransmitters, such as the 5-HT2A receptors and the histamine receptors. As previously stated, there are two classes of antipsychotic drugs. The first generation, or typical antipsychotics, act in both the extrapyramidal and limbic brain regions at the D2 dopamine receptors. The second generation, or atypical antipsychotics, have less affinity for D2 receptors and less incidence of movement disorder side effects, generally having antagonistic activity against serotonergic receptors. Regarding the typical antipsychotics, the mechanism of action, as previously stated, is that they interact with the D2 type receptors, specifically those in the mesolimbic mesocortical pathways. Classifications are as follows, including the phenothiazines, the Thioxanthines, and the Butyrophenones. The side effects mainly depend on the binding profiles of the agents being used. So if there's H1 antagonism, there's probably going to be sedation. Serotonergic receptors antagonism can lead to weight gain. D2 antagonism can lead to extrapyramidal side effects, prolactin release. And muscarinic antagonism can lead to urinary retention, dry mouth, blurred vision, constipation, tachycardia. Alpha-1 antagonism can lead to orthostatic hypotension and tachycardia. Starting with the first classification, we have phenothiazines. Regarding its SAR, the base structure of phenothiazines have no antipsychotic activity on its own. An electronegative chlorine atom at position 2 is responsible for imparting asymmetry and creates an electron withdrawing group at position 2, which increases the activity of the molecule. Substituents at position 1 and 4 decrease that activity. A side chain amine at position 10 is also required for activity. A minimum of 3 carbons is needed to separate the 2 nitrogen atoms, and 2 or 4 carbons greatly decrease that activity. In addition, a chain of 2 carbons has increased affinity for the acetylcholine and H1 receptors, increasing the side effects. Tertiary amines provide more activity than secondary amines. Branching on the side chain with large groups decrease activity, and the nitrogen substituents can be either aliphatic, piperidine, or piperazine terminal end substituents. In combination with the electronegative chlorine, it's responsible for attracting the amine side chain closer to its position, towards the ring to which it's bound. Continuing on the idea of nitrogen substituents, the activities vary depending on the structure of the side chain, as shown in the table below. And the following table just shows a list of examples of antipsychotics that are phenothiazines. The duration of action of neuroleptics with a free hydroxyl moiety can be prolonged considerably by the preparation of long-chain fatty acid esters. Ester prodrugs are more lipophilic than the parent drug. Thus, when administered intramuscularly, they are slowly absorbed into the plasma from the site, and in the plasma, the esters are efficiently hydrolyzed to the pharmacologically active parent drug. Metabolism is of major significance when assessing the effect of these drugs. However, information about many antipsychotics is lacking. Generally, though, the liver macrosomal cytochrome P450 catalyzed metabolic pathways for neuroleptics are similar to many other drugs. For phenothiazines, the 7-hydroxyl metabolite is an active anti-dopaminergic, while the sulfoxide, S double bond O, metabolite is inactive. The metabolic pathway can be seen in the picture here. For thioxanthines, the nitrogen atom in the phenothiazine is replaced with a carbon atom, which forms a double bond with the first carbon in the side chain. The Z-cis isomer is more active than the E-trans isomer, and the electron withdrawing group at position 2 is necessary for activity. Here the pictures below show examples of thioxanthines. All butyrophenones with neuroleptic properties have the following base structure. Regarding the SAR, the attachment of a tertiary amino group to the fourth carbon of the butyrophenone skeleton is essential for neuroleptic activity. Variations are possible in the tertiary amino group without loss of neuroleptic potency. For example, the basic nitrogen usually is incorporated into a numbered ring, piperidine, tetrahydropyridine, or piperazine, that is substituted at the para position. Lengthening, shortening, or branching of the 3-carbon propyl chain decreases neuroleptic potency. Replacement of the keto moiety, for example with the thioketone group as in the butyrothionenes, with olefinic or phenoxy groups, or reduction of the carbonyl group, decreases neuroleptic potency. Most potent butyrophenone compounds have a fluorine substituent in the para position of the benzene ring. Butyrophenones have less prominent autonomic effects than the phenothiazine-type antipsychotic drugs, and only mild hypotension occurs. Haloperidol has moderate sedative effects that are less than those observed with phenothiazines. It causes only mild hypotension and is less prone to induce weight gain. A major side effect is extrapyramidal symptoms due to its higher affinity for D2 receptors. This is the typical oxidative metabolic pathway of the butyrophenones, as represented by haloperidol. Modification of the haloperidol-butyrophenone side chain by replacement of the keto function with di-4-fluorphenylmethane moiety results in diphenylbutylpiperidine neuroleptics, such as pimozide, penfluridol, and fluspirylene. The diphenylbutylpiperidine neuroleptics have a longer duration of action. Regarding atypical antipsychotics, their efficacy depends on their actions on both the dopamine D2 type and serotonin 5-HT2A receptors. The high 5-HT2A receptor affinity of second-generation antipsychotics may account for their low propensity to cause extrapyramidal side effects, but the reduced affinity for D2 receptors likely also plays a role. Antagonism of the presynaptic 5-HT2A receptors that inhibit dopamine release from the striatal dopaminergic nerve terminals could increase dopaminergic neurotransmission in the striatum to modulate postsynaptic D2 blockade and reduce extrapyramidal side effects. They also have various effects on adrenergic, muscarinic, and histaminic systems. The classifications are as follows. We have benzamide derivatives, benzazepine derivatives, benzisoxazole and benzisothioazole derivatives, and miscellaneous derivatives. Starting with the benzamide derivatives, we have metoclopramide. They antagonize dopamine D2 type receptors in the chemoreceptor trigger zone of the brainstem, and the antagonism of the D2 receptors in the myenteric motor neurons increases acetylcholine release to result in a prokinetic effect on the gastrointestinal tract. It also binds to serotonin 5-HT3 and 5-HT4 receptors with low affinity, which accounts for its effects to lower esophageal sphincter tone and stimulate antral and small intestine contractions, making it useful to treat esophageal reflux disease and to promote gastric emptying. Metoclopramide is an efficacious antiemetic drug that modifies gastric motility, but it's not clinically effective for psychosis. Next, we have sulpiride, which produces a relatively low incidence of extrapyramidal side effects, and it also has hydrophilic properties, which lead to poor oral absorption and limited penetration into the CNS, resulting in low potency. Next, we have rimoxipiride, which is comparable to haloperidol in potency and efficacy, but has less incidence of extrapyramidal side effects and autonomic side effects. but it does have life-threatening aplastic anemia, and which was reported with its use, which prompted its withdrawal from the market. Moving on to benzazepine derivatives, the dibenzazepine heterocycle is a lipophilic structure with very weak basic properties. The piperazine substituent at carbon 11 providing a center, N4, of basicity for H2O solubilizing salt formation to facilitate oral dosage formulation. Now, an example of the dibenzodiazepine derivative, clozapine. Clozapine have minimal extrapyramidal side effects and do not produce tardive dyskinesia with long-term use, and they also appear to effectively alleviate the negative symptoms of schizophrenia. However, they have potentially fatal agranulocytosis that is reported to occur. Incidence of clozapine-induced weight gain is the highest among second-generation antipsychotic drugs, except olanzapine, and clozapine also reduces a higher incidence of sedation and seizures. They have a higher affinity for D4 receptors compared to D2 receptors, and they block muscarinic and 5-HT2A receptors. Clozapine is orally active and metabolized mainly by CYP1A2 with an important contribution by CYP3A4. Main products of metabolism are inactive hydroxyl and N-oxide derivatives. Olanzapine shares close chemical structural resemblance to clozapine and has a similar receptor binding profile, except it has a higher affinity at the dopamine D2 and serotonin 5-HT2A receptors. The side effect profile is similar to clozapine with the exception of agranulocytosis that does not usually occur with olanzapine use. Olanzapine is well absorbed after oral administration and is metabolized mainly by CYP1A2 to an active metabolite similar to those seen with clozapine, along with methyl oxidation and phase 2 glucuronidation. Loxapine has high affinity for dopamine D2 type receptors, serotonin 5-H2 type receptors, and histamine H1 GPCRs, but relatively low affinity at muscarinic sites. Loxapine undergoes phase 1 aromatic hydroxylation to yield several phenolic metabolites that have even higher affinity for D2 type receptors than the parent drug. Loxapine also undergoes N-demethylation to form amoxapine, which is used to treat depression, for example. As with loxapine, aromatic hydroxylation of amoxapine produces metabolites that have D2 antagonistic activity similar to haloperidol. Moving on to quetiapine, it binds with high affinity at histamine H1 GPCRs and with moderate affinity at dopamine D2 and D3 receptors, serotonergic 5-HT2A receptors, and adrenergic alpha-1 and alpha-2 receptors, as well as muscarinic M1 GPCRs. Quetiapine is also 100% bioavailable. It undergoes first-pass metabolism with major products such as the sulfoxide, catalyzed by CYP3A4, and the carboxylic acid. It can also be metabolized to 7-hydroxyquetiapine, which can then be oxidized by human myeloperoxidase to form quinone imine, which leads to neutrophil toxicity. Now, moving on to the benzisoxazole and benzisothiazole derivatives. As can be seen in the figure here, when you replace the Y moiety with an oxygen, it leads to the formation of a benzisoxazole. If you replace it with a sulfur, it leads to the production of a benzisothiazole. Starting with risperidone, it has a very high affinity for serotonin 5-HT2A and high affinity for dopamine D2 GPCRs. It has zero affinity for all 5 muscarinic GPCRs. It also alleviates the negative symptoms of schizophrenia, and risperidone, as well as its active metabolite, demonstrates a higher incidence of extrapyramidal side effects compared to other second-generation antipsychotics, and they are associated with risk of development of tardive dyskinesia and also produce significant weight gain. Risperidone is well absorbed orally and undergoes hepatic CYP2D6 and CYP3A4 catalyzed N-dealkylation and 9-hydroxylation to produce an active metabolite called paliperidone. It is not extensively metabolized by the liver and is excreted largely unchanged through the kidney. Ziprasidone has high affinity antagonist activity at 5-HT2A, 5-HT2C, and D2 receptors. The 5-HT1A partial agonist activity contributes to its relatively low incidence of extrapyramidal side effects and low propensity for inducing weight gain. It has an oral bioavailability of approximately 60%, which can be enhanced in the presence of fatty foods. It's also extensively metabolized by aldehyde oxidase, which can result in reductive cleavage of the SN bond and then by S-methylation. Ziprasidone can also undergo CYP3A4 catalyzed N-dealkylation and S-oxidation, and all metabolites are inactive. Moving on to the miscellaneous neuroleptics, we are going to start with aripiprazole, which is an aryl piperazine quinolone derivative. It's a partial agonist at D2 type with D3 and D4 receptors, whereas D2 antagonism or inverse agonism produces extrapyramidal and hyperprolactinemia side effects. In fact, the D2 type functional activity of aripiprazole depends on the anatomic location and type of cell that expresses the D2 type receptor. That is, aripiprazole is a functionally selective drug. Thus, it is a full agonist that activates brain dopamine D2 autoreceptors to negatively modulate dopamine synthesis and release, and it is a partial agonist at the 5-HT2A and 5-HT2C receptors. The 5-HT2C partial agonist properties of aripiprazole may reduce its potential for weight gain because 5-HT2C activation is associated with satiety. It has good oral bioavailability and undergoes hepatic CYP3A4 and CYP2D6 catalyzed N-dealkylation and hydroxylation as well as dehydrogenation to dehydroaripiprazole, which is an active metabolite. Moving on to minondone, it's a tetrahydroindolone derivative and it's structurally unrelated to any of the other marketed neuroleptics. It has no appreciable affinity at serotonin, cholinergic, adrenergic, or histaminergic GPCRs. And at dopamine D2 GPCRs, its affinity is less potent than haloperidol, but it can still produce some extrapyramidal side effects, and it's readily absorbed and metabolized when given orally. For serotindole, it's an indole-containing compound with high affinity at serotonin 5-HT2A and 2C, dopamine D2, 3, and 4, and adrenergic alpha-1A GPCRs. It has no affinity at cholinergic M1 to M5 GPCRs, and it's as effective as haloperidol in the treatment of acute and chronic positive symptoms of schizophrenia, but with much lower incidence of extrapyramidal side effects and better at treating negative symptoms. It's relatively non-sedating and it has active metabolites. This concludes the presentation. Thank you guys for tuning in. I hope you understood everything. And don't hesitate to ask any questions in the comments below.